Welcome, everybody. Hope you enjoyed your coffee. Welcome to this next session. My name's Rob Horn. I'm Professor of Behavioural Medicine at UCL and the UCL lead for CASME Academic. And it's a great pleasure to be involved in this symposium. I found the first session fascinating. This next session is titled The Human Person and the Communication of Risk. And we might kind of subtitle it, Putting the Person into Personalised Medicine. I think it builds on some of the things that we've heard in the first session. In Josh's first slide, for example, there was a definition of personalised medicine which went something like, it improves the stratification and timing of healthcare by utilising biological information and biomarkers on the level of molecular disease pathways. But even if we can deliver on the promise of this, and I think Tim's talk should cause us pause on exactly what that might look like, but even if we can deliver on the technological advance, its impact on health and wealth will be determined by behaviours, how we implement the technology, and by patient perceptions and engagement, as John's talk illustrated using his example of single-day, once-a-day treatments for diabetes. This will also apply in personalised medicine. Tim introduced the sort of classic example of Gleevec as a personalised medicine success. Yet Marin's study conducted a few years ago at Imperial showed that its efficacy in practice was compromised by patient non-adherence. So, coupled with John's example, I think this illustrates a key pitfall in the original conceptualization of personalized medicine, and that is the failure to personalize care to the psychological and behavioral factors, the psychosocial factors that will determine engagement and adherence. So if we are to realize the promise of personalized medicine, we kind of need a better understanding of how perceptions of value and risk will shape behavior at the level of the individual, organizations, and society. And one could argue that innovation in that field is as important as innovation in the biological field. So we're going to explore these issues in more detail in this session, maintaining our multidisciplinary focus, and beginning with Dr. Sian Rees, who's on my right, Director of Oxford Health Experiences Institute and Patient and Public Involvement Lead for the Oxford AHSN. And Sian will examine these issues from a public health and patient engagement perspective. That'll be followed by Professor Alastair Kent, who's Director of the Genetic Alliance UK and Chair of Rare Disease UK, who will provide a perspective which draws on his work with over 370 patient organizations, healthcare professionals, researchers, the pharmaceutical industry, and of course not least individual patients and families. And then lastly, Josh Horden, who convened the session and is Associate Professor of Christian Ethics at the Faculty of Theology and Religion here at Oxford, will examine the issues from an ethical perspective, focusing particularly on notions of self in health and illness. So enough, more than enough from me. Let me hand over to Sian.
Thank you very much, Rob. Okay. Is this on or working? Okay, let's do it on here then. That's easier. Okay, I'm going to talk a little bit about personalising medicine. And I'd like to start by asking the audience, who's this? Anybody? A clue is his proper name is Philippus von Hohenheim. Yes, thank you very much. So, AKA Paracelsus. So why might we start a sort of very modern discussion about medicine by looking at a 15th century doctor, alchemist, and heretic? Well, Paracelsus was clearly a scientist. He used observations of nature rather than ancient texts, which was prevalent at the time. He also developed the idea of a dose-response relationship, and so founded toxicology in some ways. But his ideas of the processes of life were actually much broader than that. He was one of the first people to understand that some diseases might have psychological origins, and indeed is credited with the first descriptions of what we now sort of understand as the unconscious. And the reason I put this up is because he said something which I really like. And he made this distinction between medicine being both a science and an art. And I really like this because it took me a really long time to get it. I went into medicine seeing it very much as a science. You know, I was good at sciences at school, my dad was a doctor, that sort of thing. I wanted to make a difference as well. And it took me a long time to really understand the limitations of that approach. And so this is really a plea that we should see personalised medicine not sitting with the science of medicine, but very much sitting with the art of the endeavour. So, just to think a little bit about what we're talking about. Personalised, fairly obviously, to make personal. There are lots of ways of thinking about what personal means. Just a few of the sort of dictionary definitions. And the one I like particularly is belonging to or affecting a particular person rather than anyone else. So what might we need to know to personalise, to understand what matters or what affects a particular person? Undoubtedly, we might need to know something about their genome, because it belongs to us and only us, and that by understanding it and understanding an individual's genetic makeup, we may help in determining a personalised treatment plan for them. However, it's also clear that what affects us must be a broader, more encompassing definition of actually what matters. What do we value? And so, I invite you, just for a moment, to think about what matters to you, and to hold the first image that comes into your mind. For me, the first image that comes to my mind is this. This is me with short hair. This is my dad who's asleep, quite common. This is my son who's actually now 19, somewhat bigger than that. And these are sort of brothers, sisters, nephews, nieces, in-laws. And one of the things that really matters to me is the nature of relationship. And so when thinking about extending from my family into my work, it really is the nature of relationship that made me to start understanding what Paracelsus might have been getting at when he talked about the art of medicine. I guess that there will be a wide range of pictures and ideas in people's heads across the room, and I'm not going to ask you what they were. And there will be, I'm sure, a lot of synergy in that. But it will definitely be true that they will be particular and personal to you. So, to go back to the question, one way of thinking about personalisation might be, and I think it was mentioned in the talks just now, the right care for the right patient at the right time. And so, please could you consider the following. If we take two patients, medically identical health state, identical diagnosis, different doctors, different treatments. Is there a problem? Please could I have a show of hands who thinks that this is a problem? Nobody thinks that's a problem. Okay. Well, actually, maybe it is. Show of hands, who thinks it's a problem? Okay, maybe a problem. Okay. So some people think it might be a problem, and some people think it may be a problem. And of course, the maybe is right. It may be that actually you just got the bad luck to get Dr. A who just gave you the wrong treatment. Incorrect treatment. It may be that there's genuine uncertainty in treatment options, and that Dr. A prefers treatment A, and Dr. B prefers treatment B, and the outcome, cure or not, is the same. It's also possible, based on discussions today, that actually you might take different treatment approaches based on risk stratification. I didn't mention that people were genetically identical at the beginning, so you might say that treatment A is appropriate for risk stratified patient group A or risk stratified patient group B. However, you might also say that actually one of the important aspects of thinking about this is patient preference. And so patients may very genuinely have a preference for treatment A versus treatment B. So for treatment of mild and moderate depression, psychological intervention versus pharmacological intervention. Or also importantly, they may have a preference for outcome, for different outcome states. The sorts of things that are classically talked about here are really about the sort of end-of-life care. So if I have got to face my third round of chemo for ovarian cancer, and I really had a bad time second time round, and it's going to give me a very marginal increase in life expectancy, I might just say, no, I've had enough. However, if that 6 weeks it gives me allows me to see the birth of my first grandchild, then I might feel very differently about it, and I will tolerate the decreasing quality of life for those 6 weeks in order to be there, or potentially be there. And so those sorts of decisions are personal, they are individual, and they are absolutely as important. It is no better to treat a patient with the correct drug if you take no account of their preference for either treatment options or outcome options. So it's what matters to this patient in the context of their lives. And just before we think whether or not healthcare professionals are indeed good at thinking about preference, so you could argue that actually, well, you know, doctors and nurses and healthcare professionals in general are good at knowing what the preferences that patients might have are. This is a study which I like, and it compares the difference between clinicians and patients when thinking about ranking the sorts of goals and concerns for breast cancer decisions. A list of 10 goals and concerns that are important to patients, and then you ask people what the top 3 are the most important ones are. This is what clinicians say as being the most important. So 96% of them thought that it was in the top 3 to think that living as long as possible was important. Whereas avoiding using a prosthesis was not in the top 3 as far as clinicians are concerned. If you compare that to what patients say, you get a somewhat different picture. And it's a small study, but those are pretty significant results. And it just says that actually patients don't think the same way as clinicians. And I suspect clinicians, when they're patients, may not think the same way as they are when they're clinicians always. Similarly, we might say, well, actually, you could argue that relationship doesn't really matter in terms of clinical outcomes. That actually it's okay to just treat and get the clinical outcome that's a good outcome. There isn't a lot of research in this field, but there's an increasing amount. This is a study that looks at 800 odd patients and I think 29 physicians, and looks at clinical outcomes in diabetes. So it says actually one of the sort of things that you need to be that's good in diabetes is to control your HbA1c, to control your glycosylated hemoglobin. And this suggests that actually if you look at measures of empathy amongst the physicians, those physicians that have high measures of empathy get better clinical outcomes for their patients. Now, this does not show a causal relationship, it's simply an association. But it's an association that is based in relationship, and it's an association which goes beyond our understanding of molecular bits of the body, or even the sorts of disease processes that matter. It says something about the way in which we interact with our patients being important. So, if we think about quality in care, and we think about personalised medicine as being something that is about perhaps improving quality in care, when we often think about these 3 sort of domains as being important aspects of quality. And it's undoubtedly true that safety and effectiveness are likely to be improved by improving our understanding of science. It doesn't sit very easily, though, that actually those things are necessarily going to improve experience. You could argue that actually by getting the right treatment and you're being better, then it improves your experience of care. But actually, what we know from research is that experience of care is very much seated in the nature of relationship and not in the nature of the actual intervention itself. And for me, the idea of personalisation has to sit somewhere in the middle of that. So if we think that actually personalising care is to make care that is responsive and respectful to the needs, preferences and values of individuals, then we have to be able to consider all 3 of those areas equally. The needs may well be clinically defined. They may also be defined by an individual patient as well, but preferences and values are things that are very personally defined and not easily defined by anybody except the person themselves. And so perhaps it's preferable to think about personalised care rather than personalised medicine. If we're going to think about what personalising care might be, then actually we think about personalised care planning, and that includes an understanding of individual risk based on biomarkers or genetics, or indeed just simply belonging to a population group. It also, as I've pointed out, that actually this is about the way in which people think about the preferences they have for particular treatments or outcomes. In order to personalise care, we have to have some processes around shared decision making, and we have to know what outcomes are important to patients. Of course, one of the challenges in this is that actually we also know that in order to communicate and allow someone to share a decision about their care and treatment, we have to be able to tell them something about the risks and benefits. We have to be able to communicate those risks and benefits in a way that they will understand. And that means we have to understand the risks and benefits ourselves. Unfortunately, Gert Gegerentz's work and David Spiegelhalter in this country show quite clearly that doctors are not good at either understanding risk, and if they do not understand risk any better than the general population, then they find it very hard to communicate it. So the idea that we can personalise and allow not just an understanding of somebody's genomic structure to be part of the decision making for them or their preferences, we have to be able to have that communication as a fundamental part of the consultation. And we don't concentrate as much as we might. We concentrate a lot on teaching people about the science, but not so much, although it's improved since I qualified, it's not so much about the nature of how you communicate risk and how you actually allow people to make informed decisions about the care that they wish to receive. And so, just to wrap up, for me, it's the capacity for relationship and the ability to elicit a person's feelings and preferences that is the art of medicine. And that's where personalisation truly sits. It's not to say that the science isn't important, it clearly is. But actually, if we do not have a focus on the art, and that means a focus in practice, it means a focus in education, and a focus in research. I think Sally Lamb just mentioned earlier, we have a very unfair playing field, perhaps, when looking at the sort of areas that are as important to patients and ultimately important to their outcomes and consequently to society in terms of funding of research or in terms of the way in which we teach medicine or nursing. We don't concentrate on the art. So